Here is your question. Right. If you have read and understood, let's begin.
Yeah.
Anatomy station. Can you please help me and identify what you're looking at?
This is a right popliteal fossa posterior view.
Okay. All right. Can you please help me to identify, or first tell me what are the boundaries of the popliteal fossa? How is it formed?
The popliteal fossa is a diamond structure which is
Yes.
formed superiormedially. We have medial head of the biceps. Superiormedially we have
Semi. Yes.
semimembranosis and semitendinosis,
Good.
and superiorlaterally we have biceps femoris.
Yes. And
Inferiorlaterally we have medial head of gastrocnemius, and inferiorlaterally we have lateral head of gastrocnemius. Floor
roof and floor. Yes, please.
Roof is formed by skin, superficial fascia, and fat, and floor is formed by the knee joint and knee capsule.
Yes, in the roof there is also a deep fascia which is pierced by the short venous vein. And in the floor, okay, you said popliteal surface of the femur, posterior aspect of the knee joint, and the popliteus muscle. All right. Can you please tell me what are the differential diagnosis would be like for a popliteal lump? Can you name
For
few?
popliteal lump starting from the skin, on the skin we can have an abscess or a lipoma.
Yes.
Going down, we can have a lymph nodes or
Sebaceous cyst and
sebaceous
sarcoma
cyst.
as well in the skin, and then vessels.
And the vessels, we can have a popliteal aneurysm.
Yes.
From the vein, we can have a varicosities,
Yes.
staphylococcus, and
Yes.
from the nerves, we can have a neuroma.
Very good. And
From the
from
bone, we can have a
musculoskeletal,
fracture. We can have a
knee joint effusion,
knee joint
sarcoma,
effusion
and
and a bursae.
tumor of the femur or tibia. What else can you have here? Lymph node, enlarged lymph nodes.
Yeah, as I saw.
Yes. Okay. Can you tell me what are the contents of the popliteal fossa?
From superficial to deep, we have common peroneal nerve, which divides into superficial and deep at the head of the fibula. Then you have the tibial nerve. Superficial to deep, you have saphenous vein, short saphenous vein, sural nerve. Coming down, you have common peroneal nerve, then tibial nerve, then and posterior tibial artery and vein.
Okay. What is the
Sorry,
deepest
popliteal
structure?
artery. Sorry, it's a
So
popliteal
vein
artery.
and then artery. What is
Yeah.
the deepest structure in the popliteal fossa?
Deepest structure is the popliteal artery.
Can you please tell me the branches of the popliteal artery?
Popliteal artery divides into two main branches. One is the anterior tibial artery and the tibio-posterior trunk, which later on divides into peroneal artery and posterior tibial artery.
Okay, can you identify the structures that you're looking at? Number 11 maybe?
Number 11 is it gracilis?
Okay, we'll go through at the end.
Yeah,
15 please. Where is cursor? Here. 15 please.
that's a popliteal artery.
17 please.
Um,
Where
no,
is
sorry, it's not
cursor?
popliteal artery. It's the sciatic nerve, which is dividing into the. It's a tibial nerve. 17 is
Okay,
tibial nerve.
we'll go through it at the end. Right. Number 2 please.
Common peroneal nerve.
1 please.
Biceps femoris.
Okay, 13.
Short saphenous vein.
14.
No idea.
All right. Moving here, 8, if you can see.
That's the popliteal artery, I guess.
16, please.
I'm just gonna guess. Sorry.
That's all right. We'll go at the end. 16, please.
Sorry, which one?
16.
It's a nerve. Well, I'm not sure which one is it.
12, please.
Semimembranosus, tendinosus.
Okay. Can you please tell me, right, if the question is, in which compartment does the tibial nerve run in the lower leg?
Tibial nerve supplies the posterior compartment.
Okay. In which compartment does the deep peroneal nerve run?
Deep peroneal nerve supplies the anterior compartment.
Okay. What would be the consequence of section of superficial peroneal nerve?
Patient will develop a foot drop, and the sensory loss will be on the numbness on the dorsum of the foot, except the first web space, and the motor-wise, they will struggle to do eversion of the foot as it supplies the motor muscles in the lateral compartment of the leg.
Please tell me, what is the function of popliteus muscle?
Popliteus muscle helps in the unlocking of the knee joint when persons tries to stand up from flexion to extension.
Okay, initiating stages of flexion from full extension. Okay,
Extension effect.
all right. You told me something. Okay, what kind of joint is knee joint, please?
It's a synovial joint.
Okay, tell me please more. What are the muscles or ligaments or structures which strengthen the knee joint?
So knee joint is I think it's a hinge type of joint of a
Yes.
synovial joint, and it has intra-articular and extra-articular ligaments.
Okay.
The main ones are the anterior and the posterior cruciate ligaments. It has
And
two menisci which act as shock absorbers, and it has two medial and lateral collateral ligaments.
yes.
And then they have muscles which help in the movement of the knee joint, which are the
Okay.
dynamic
What are
stabilizers.
those muscles?
So the muscles which help in the flexion of the knee joint are, give me a second. The muscles which help with the flexion are the hamstring muscles, which help with the knee flexion. And then we have knee extension muscles are.
How many compartments there are in the lower leg?
We have 4 compartments, 3 main compartments, and then posterior compartment is divided into superficial and deep. So anterior compartment, lateral compartment, and then posterior compartment.
Okay. Can you please name the structures which pass through the medial malleolus? Pass behind the medial malleolus.
From anterior to posterior, we have tibialis anterior, then we have flexor digitorum longus, then we have anterior tibial artery and vein, then we have
Okay.
tibial nerve followed by flexor helicis longus, and lastly, flexor helicis longus, the last one,
Okay. Can you please tell me how many bursae are associated with the knee joint?
So we have a suprapatellar bursa, we have the prepatellar bursa, we have the infrapatellar bursa, and there is one more, so we have 4 bursae.
Okay. What is the inflammation of bursae called?
Bursitis.
How would you manage that?
The bursitis are usually managed with the antibiotics, or if it's inflamed, otherwise we just wait and watch.
Good. Okay. Right. Thanks. Thank you.
That's what's crap.
All right. We wanted to go through the structures. Right. What did you say 11 was?
I thought it was gracilis, but I don't think it's gracilis.
Semi-membranous.
So that's semi-membranous, okay.
Okay. And then what else you said you don't know?
Sorry, which one?
Which others you said you don't know?
I think I was wrong almost all of them.
Would anyone else want to tell her? 8 is popliteal artery. 8 is here. You were sure about that. You had this correct.
Because
8
it's
is
a deep one,
popliteal artery.
that's a deep one.
Yes, and then 2 was common peroneal nerve.
Yes.
1, this one is biceps femoris.
Biceps femoris, yeah.
3 is gastrocnemius. 3 is here.
Yeah.
All right, and then 14, this one is sural nerve.
Sural nerve.
13 was small venous vein.
Okay.
See, this is like lumen kind of thing. And then
What was 16? What is 16?
it's some vessel. I'm trying to locate it myself. Okay, just a second. In looking for in knee 228 in the atlas. Quickly, if I can find it. All right. Sixteen was tibial nerve, muscular branch.
Okay.
Yes. 7 was plantaris.
15 is sciatic nerve, right? And 17 is tibial.
15 is tibial nerve, and
Okay.
16 is tibial nerve muscular branch.
And 17?
17 is sural nerve.
That's sural nerve. It's
Yes.
too big for sural nerve.
I don't know, magnified, but this is what it says
Okay.
on Macmillan page 330. Right, good, thank you. Okay. Starting the timer, and here is your question. Right, if you have read and understood, kindly tell me, considering a critical care scenario, how would you manage this patient?
Ma'am, I'll be managing this patient according to ATLS protocol. First of all,
Yes.
as a patient, GCS is 8, and there is a clear indication to intubate this patient.
Okay.
And after the intubation, I make sure the patient has adequate ventilation. And once the airway and breathing has been managed along with the cervical spine immobilization, my next step would be about on the circulation with 2 large bore IV cannula, sending the blood for cross match, and make sure I do not overhydrate the patient to reduce the risk of cerebral edema.
Very
In
good.
these patients,
Okay.
ma'am,
This was my next question. Yes.
in this patient, we have to monitor the intracranial pressure. As the
Yes.
patient has deteriorated the GCS, there are lots of ways to do so. So whatever would be the convenient and the possible we'll be doing in that particular scenario, it can range from least invasive to highly invasive. And then later on the disability, I'll be checking the patient GCS, and it's now 8, and along with that, the pupils on the both side and the
What are
patient
the
sugar.
ventilator settings that you'll keep or you'll consider?
In this patient,
Yes.
ma'am, I'll set the respiratory rate to be higher side, and the patient would be
Yes.
on the CME mode, sedated, intubated, relaxed,
Yes.
along with the respiratory rate would be high because my main motto would be to hyperventilate the patient and to maintain the normal carbia. So that's why I
Okay.
had to hyperventilate the patient.
Good. Okay. Can you tell me what is the normal intracranial pressure?
I'm usually between 7 to 15 millimeter of mercury.
Okay. In supine and in standing?
Yes, in supine. Sorry, in standing.
What
I
can
don't
you
know.
name few ways with which you can measure intracranial pressure, both
Okay.
invasive and
Ma'am,
invasive?
okay. They basically are they're wide variety to do so. It basically sway from the way least invasive to invasive,
Yes.
starting from the transcranial Doppler assessment to the extracranial through the extradural probe, interparenchymal probe, subarachnoid probe, and then you can go for the lumbar pressure monitoring, and then which is the other, which is the gold standard, is the intraventricular drain and extraventricular drainage.
Okay, good. Can you define the term Cushing triad? What do you
Okay.
understand by it?
Okay. Whenever there is an increase in intracranial pressure, that is according to Kelly-Monon-Dictroin hypothesis that this cut is basically a rigid structure. This lead to the uncal herniation and compression of the third nerve, and with this uncal herniation, this will lead to the three symptoms, which are basically bradycardia, hypertension, and widening pulse pressure and irregular respiration.
How
And
would
that is
you,
a basic sign of
yes,
impending herniation, impending coning.
how would you differentiate it from Cushing reflex?
Sorry, ma'am.
Yes, how would you, okay. Can you explain Monro-Kelly hypothesis or
Monoclonic.
pathophysiology of increased intracranial pressure?
Okay, ma'am. Monro-Kelly hypothesis says that the skull is basically a rigid structure which basically comprises of three components, starting from the brain,
Yes.
CSF, and the blood. If one of them has to be increased, the other has to be decreased in order to compensate that. If the basically compensation and autoregulation has been superseded and the ICP has lead to 25 millimeter of mercury, this compensation cannot be occur, and that will lead to the herniation.
And fail. Okay, very good. Okay, can you tell me why the patient had GC Glasgow Coma scale 15 and after a few minutes it was 8? What had happened to the patient?
Ma'am, this is a basically classical presentation of a lucid interval.
Can you define the term lucid interval, please?
In lucid interval, there is a temporary improvement in the patient GCH and consciousness, followed by the sudden deterioration, in which basically occur is that the first the patient become unconscious due to trauma. Later on, patient got a bit consciousness, and in this time period, the patient blood which has due to blood which is being accumulated in outside the dura due to the rupture of meningeal artery get increased in the size, and that due to the compression and later on the deterioration of the GCS.
Very good, very good. Okay. Can you tell me how would you calculate mean arterial pressure
Okay, ma'am, it can
or
be done.
cerebral perfusion pressure? I want to know actually. How would you calculate?
Okay,
They can ask
ma'am,
you, yes.
it can be done by minusing the mean arterial pressure from the internal cranial pressure, the MAP minus ICP.
Okay, good. All right. And in case of traumatic brain injury, it would be,
Ma'am, it is usually between 50 to 150 millimeter of mercury.
yes. Good.
In a traumatic brain injury, it can basically either could be decreased or increased.
All right. In this patient, what are the indications? When would you ask for CT scan to be carried out?
Ma'am, there are two criteria. The one is the NICE guideline, other the Canadian criteria.
Tell me
Basically,
about the NICE guidelines, please. Yes,
okay, ma'am, in
accordingly.
NICE guidelines, okay. And NICE guidelines says if the patient has presented to you with the GCS less than 13 at the time of presentation, or the patient has the GCS less than 13 at the second hour of the injury, and along with that the patient has the episode one or greater than 2 episode of the vomiting, and the patient has a history of a loss of consciousness, and
Yes.
the patient has any sign and symptom of the basal skull fractures, such as hemotympanum and otorrhea rhinoria or a battle sign and the raccoon's eye. And along with that, the patient had the hemotympanum, and the patient had the open or depressed skull fracture, any focal neurological deficit, any history of or any seizure, or patient age greater than 65, or the patient has any history of using a clotting anti-clotting agents. And along with that, there are certain special indication in which it can also be done, in which the mechanism of injury has to be taken in mind. If the patient has
Good.
been ejected from a very fast vehicle, or the patient or either being pedestrian and has been hit by a high speeding vehicle, so or the patient has been fall from at least 5 feet or the 3 stairs, so these all things has to be taken in the mind in such patients.
Excellent. In this case, if you'll do the CT scan, what do you expect to see?
Ma'am, more likely as per the presentation of the patient, the patient and the young age of the patient, it's more likely to be the extradural hematoma, as the image that you have shown to me. This is a basically axial scan of the CT brain and bone window, showing right-sided temporoparietal biconvex hyperdense lesion, along with the cerebral edema and midline shift and compression of lateral ventricle. So it is complying toward the EDH of the right side.
Very good. Okay. Can you please tell me, how would you take care of the nutrition of this patient in this condition?
Okay, ma'am, if the gut is intact, we can start the enteral nutrition by placing the NG, even if the patient GCS is lower down, and we can start the enteral nutrition within the 6 hours of the patient has the trauma.
Okay, would you consider lumbar puncture for this patient?
Ma'am, no, the patient who had the basically cerebral edema, we should not. There is a sign because that might lead to the herniation.
Okay, how would that present? What causes the dilated pupil in case of raised intracranial pressure?
Ma'am, that is due to the basically compression of oculomotor nerve, which basically supply the parasympathetic fibers to the pupils. So if that interrupted, that lead to the unopposed action of sympathetic nervous system and dilatation of a pupil.
Okay, if the patient has dilated pupil and patient is intubated, how would you decrease the risk of brain injury?
And basically, you have to decrease the secondary brain injury, and that could be by decreasing the cerebral, basically decreasing the IC intracranial pressure. You are monitoring the pressure. You will reduce it by basically head up the patient 30 degree and hyperventilate the patient and sedate the patient and anesthetize the patient, providing the good analgesia. And you can use a certain osmotic diuretic to decrease the ICP, which basically range from the mannitol to the furosemide, and your range of sodium to be in between 135 to 145. Do not overhydrate or underhydrate the patient. And along with that, you can also, in the later stages, if any of these things does not work, you can go for decompressive craniectomy.
Very good, excellent. Where would you manage this patient?
Ma'am, the patient would be managed in trauma in ICU.
Yes, and who would you involve in the management of this patient?
Ma'am, I'll be involving the neurosurgeon, neurophysician, and for later rehabilitation, physiotherapist, and patient might have to have go to the rehabilitation center later on.
Very good, excellent.
Thank you, ma'am.
Nothing has been left. Everything you have covered very perfectly. So excellent.
Thank you, ma'am.
And here is the question. Yes, please. Right. If you have read and understood, let's begin our session. Can you please help me to identify what are you looking at? What are the structures? What is this number 3, please?
It is the common iliac artery.
Okay.
3.
Yes, right. And this number 1?
It is the abdominal aorta.
Can you name all the abdominal aorta's branches? All means what?
Okay. There is the anterior branches, the superior mesenteric artery and the inferior mesenteric artery and the celiac trunk.
Yes.
Also, there is lateral visceral branches, the suprarenal artery and the renal arteries, and the gonadal artery.
Gonadal vessels, yes.
It is bifurcated into the common iliac artery. And also there is the lateral branches, the lumbar arteries from L1 to L5.
Yes.
And there is inferior phrenic artery.
All right. Can you tell me at what level abdominal aorta traverses the diaphragm, the openings of the diaphragm, and what accompanies it?
12.
At T12, yes. And
It
what
was the
accompanies
common
it?
zygous vein.
Okay, good. Okay,
The
can you
zygous vein.
identify number 23, please?
This is the inferior vena cava.
Okay, can you tell me the tributaries of inferior vena cava?
Okay, there is form it at level of L5 from the
Yes.
two common iliac veins, and then ascending behind the splenic veins and anterior to the splenic vein, anterior to the head and neck of the pancreas.
Okay. And at what
And
level?
enter
Yes.
the Beer's diagram at the level of the T10 in
T10.
the esophagus.
Inferior vena
T8,
cava.
sorry.
Yes, T8.
T8.
All right. Okay. Can you please identify this 39?
This is the
Gonad.
gonadal vessels.
Yes. Here as well. See? So, okay. Can you tell me the relationship of gonadal vessel with the gonadal branches of the abdominal aorta? Or is it the same? Or with the ureter, sorry. Gonadal vessels with the ureter. At the brim of the pelvis.
It is at the level of the L2.
Okay. But what is the relation? Is it anterior or is it posterior to ureter? Okay, we'll come back to that later. Okay, can you
Anterior
identify
to the
all the
ureter.
structures from A to H, please? What is A?
Okay.
Yes. Can you identify
The
all the
gonadal vessels
structures?
anteriorly to the ureter.
What is A? Yes, please. Can you identify the structures? Dr. Mohammed. Can you please identify the structures? What is number 1? Number A?
Hello?
Yes, please. What is number A? Can anyone
Hello?
else? Yes, please. Yes, can you identify
A, this is the right renal artery.
right renal vein? Okay, what is B? What is B, please? Can you identify structure B, please?
Abdominal aorta.
Very good. Number C, please. Continue. Dr. Mohammed, connect. Yes. C, please. C is this vessel. And you can see it's blue.
This is the
So,
gonadal vessel.
very good. Gonadal vein, testicular vein. All right. Number D.
Yes.
D, please. D is here. D.
D, this is the suprarenal gland,
Very good. E,
the
please.
left suprarenal gland.
Yes. E.
It is superior mesenteric artery.
Yes. Very good. F, please.
F, the left renal vein.
Very good. G, please.
And G, this is the abdominal aorta.
Very good. H.
H, this is the left ureter.
Can you please tell me what is ligament treats?
This is the ligament that connects the jejunal junction to the diaphragm.
Okay. Can you name the lateral branches of the aorta?
Hello?
Yes. Lateral branches of the aorta. We are still at aorta.
The lateral branches.
Yes.
There
Yes.
is the three lateral visceral branches. The right and
Okay.
there is the right and the left renal artery, and right and left suprarenal artery, and there is the
It's anterior visceral branches and the 3 lateral visceral branches. and then 5 lateral abdominal wall branches, and then 3 terminal branches. Anyway, okay, can you please tell me, during the operation or during surgery, you can ligate the inferior mesenteric artery and nothing, no big or serious consequence happens. Why? What is the anatomical explanation for this? One of the anatomical, yes, inferior mesenteric artery, branch of abdominal aorta, you ligate
Due
during
to
the surgery.
the marginal artery, collateral branch from the marginal arteries.
Yes, what is the marginal artery? Yes. Yes. Such as open aortic aneurysm. Okay. Can you tell me what is aneurysm? Because in the question stem I use the word aneurysm. So can you explain it? Define the term aneurysm. Okay. Can you identify all the structures from A to whatever? I, J, K, L maybe? What is A?
A right renal vein.
Very good. No, A is abdominal aorta. A is here. Abdominal aorta. What is B? Yes.
D left suprarenal organ.
B is right common iliac. It's aortogram angio.
Hello.
Yes. What is A, please? Can you identify A, please, and then B, C? We will, yes. Dr. Mohammed, are you there
A
or
is the
not?
abdominal aorta.
Yes, and B, please.
A is the abdominal aorta, and B is the right common iliac artery.
C. Bell has gone, but we'll continue. C, please. D, please. Left renal artery. E, right renal artery.
The right renal artery.
Yes. F,
Splenic artery.
Yes. G, where is C? Here, G.
G is the hepatic artery.
Common hepatic, okay.
Common hepatic
And
artery.
H is here.
H, this is the superior mesenteric artery.
Good. I is here.
This is gastroduodenal artery.
Yes. I. J.
L, this is the inferior mesenteric artery. J is the left hepatic artery.
Yes.
And K is the right hepatic artery.
K is right hepatic, and L is inferior.
Inferior mesenteric artery.
Yes, very good. Okay, good. Thank you. What is this? What are we looking at? These arrows are pointing at
This
what?
is CT abdomen.
Okay, good. And this arrow, these arrows are pointing at what? What is this?
The abdominal aorta.
Okay.
There is infrarenal saccular cyst. I don't know.
Secular,
Aneurysm.
okay, infrarenal.
Infrarenal
It's
saccular
not
aneurysm.
cyst, it's aneurysm, aortic abdominal.
Okay.
Aneurysm, okay. I asked you to define aneurysm. Can you define aneurysm, please?
This is dilatation
Abnormal,
in the arterial
yes.
wall.
Yes, abnormal dilatation of the arterial wall or aortic wall. Can you tell me what is the pathogenesis of this
Due
dilatation?
to medial cystic fibrosis.
Yes, or can even be post-traumatic when it is false
Okay.
aneurysm. Yes. Okay, good.
Yes.
Thank you so much.
Thank you.
Yes.